Hey guys, this is CT Procedures and Sectional Anatomy, Radtech 4071, and the introduction. Computed tomography was a huge leap forward in medical technology when it was first introduced in the 1970s. It's continued to improve at a very rapid rate, and now is commonplace even in very remote locations. Protocols and standards have been developed over the years that vary from location to location, but are still fairly consistent. And one thing that you're going to hear and observe from the CT technologists in the clinic setting is that there's more than one way to get the same set of images. And the reason for this is how the technologists learn from their CT training and the manufacturers of their CT scanners. So I would encourage you to be open-minded when the technologist is showing you ways to do things that seem to conflict with what other techs may have shown you. CT scanners operate differently with different manufacturers, and just like automobiles, you can spend as little or as much on extra features as you like. The main manufacturers of CT equipment are GE, Siemens, Philips, and Toshiba. There are others, but these four manufacturers seem to stand out as leaders in the industry. And if you're taking this course locally and will be utilizing the ULM clinical affiliates, then you'll have the chance to work on just about all of these machines. But as I said, regardless of the brand of scanner, the positioning and the images are still consistent. The protocols and software packages within the CT system are what vary the most. So let's start this lecture with a definition of computed tomography. It comes straight out of our Romans book. Computed tomography uses a computer to process information collected from the passage of X-ray beams through an area of anatomy. The images created are cross-sectional. To visualize CT, the often used loaf of bread analogy is useful. If the patient's body is imagined to be a loaf of bread, each CT slice correlates to a slice of that bread. The crust of the bread is analogous to the skin of the patient's body, and the white portion of the bread is the patient's internal organs. The individual CT slice shows only the parts of the anatomy imaged at a particular level. For example, a scan taken at the level of the sternum would show portions of the lung, mediastinum, and the ribs, but would not show portions of the kidneys and the bladder. Computed tomography requires a firm knowledge of anatomy, in particular, the understanding of the location of each organ relative to others. With that definition in mind, we're going to begin a discussion of anatomical planes of the body and perspective in CT viewing. So there are three major planes that divide the body. The transverse plane divides the body into superior and inferior portions. It's also known as the axial plane or cross sections, this is the most common viewing plane in CT. The second plane is the sagittal plane, which divides the body into left and right halves. And then the third plane is the coronal plane, which divides the body into anterior and posterior portions. It's also known as the frontal plane. Understanding the intricacies of CT scanning requires familiarity with those imaging planes. So we're going to look at those planes now and review some of the directional terms that you probably already know, but it's going to help us as we move along in this discussion. All directional terms are based on the body being viewed in anatomic position. This is characterized by what you see on the slide. That is, when the individual is standing erect with the palms of the hands facing forward. The terms anterior and ventral refer to movement forward or toward the face. Posterior and dorsal are equivalent terms used to describe movement toward the back surface of the body. Inferior refers to movement toward the feet and is synonymous with caudal. Superior defines movement toward the head and is used interchangeably with the term cranial or cephalic. Lateral refers to movement toward the sides of the body, and medial refers to movement toward the midline of the body. So as you look at the anatomical position with directions on the slide, you're going to see that these directions, or you're going to see directions along with the scan lines in place. So beginning at the head, The superior direction is movement toward the head and synonymous with the terms cranial and cephalic. And as we move down the model, imagine the planes as large sheets of glass, and you'll see that the mid-sagittal plane cuts through the middle of the body, dividing it into right and left halves. The coronal plane cuts through the body from the side, dividing it into anterior and posterior halves. And the axial or transverse plane cuts through the body, dividing it into inferior and superior halves. And we see the lateral and the medial directions. Lateral refers to movement toward the sides of the body, medial toward the midline of the body. And next is the posterior and anterior. Posterior and dorsal are equivalent terms used to describe movements toward the back surface of the body. Anterior and ventral refer to movement toward the face or forward. On the hand, we see distal and proximal directions. These terms are most often used in referring to extremities. Distal refers to movement toward the ends. Proximal, the opposite of distal, is defined as situated near the point of attachment. For example, the proximal end of the arm is the end at which it attaches to the shoulder. There are other imaging planes that exist that are essential to CT, and they are parasagittal planes that are located to either the left or right of midline, and the oblique planes, which are slanted and lie at an angle to one of the standard planes, and these are also called orthogonal planes. Imaging planes can be changed to show structures in a new perspective, but before we get into that, we need to talk about the X, Y, and Z axes of CT. The image on the slide demonstrates where the X, Y, and Z axes are in relation to the patient in the CT scanner. From this perspective, you can see that the X-axis is from left to right, the Y-axis is anterior-posterior or front to back, and the Z-axis is superior to inferior or head to feet. Now, each CT slice represents a specific plane in the patient's body. The thickness of the plane is referred to as the Z-axis. And the Z-axis determines the thickness of the slices. The image of the head with the Z-axis on it was turned over on this slide intentionally to correlate the patient's position on the CT table as they enter head first, to give you a better perspective on that Z-axis. So the operator selects the thickness of the slice from the choices available on the specific scanner. Selecting a slice thickness limits the X-ray beam so that it only passes through this volume. Hence, scatter radiation and superimposition of other structures is greatly diminished. The X-ray beam is limited by mechanical collimators. The data that form the CT slice are further sectioned into elements. Width, which is indicated by X, and height is indicated by Y. Each one of these two-dimensional squares is a pixel or picture element. A composite of thousands of pixels creates the CT image that displays on the CT monitor. But if we take the Z-axis into account, then the result is a cube rather than a square, and the cube is referred to as a voxel or a volume element. And this is demonstrated by the image on the right, to the right of the supine head on the slide here. The Z-axis section has been laid flat, and the voxel has been lifted out of it. The voxel lifted out of the slice represents one of the thousands of voxels or pixels used to create the image and demonstrates the X, Y, and Z axes. We'll discuss more about the X, Y, and Z axes and pixels and voxels in physics. But for our lecture today, the X, Y, and Z axes will help you orient yourself to looking at CT images in different planes. So let's talk about changing the scan planes and why we would do that. Changing the image plane shows the same structures in a new perspective. For example, if a coin is baked within a loaf of bread, lies standing on edge in the loaf, a sharp knife cutting through the bread lengthwise will show this coin as a flat rectangular density. However, if the bread is restacked and cut in an axial plane, the coin appears circular. So this slide shows that concept, and this figure is also found in your book. As you can see, the axial plane cuts through the midsection of the bread and gives a sort of face-on view of the coin. The coronal plane cuts through the loaf from the top to the bottom and gives a sort of edge-on view of the coin. So adjusting the image planes can be accomplished by by four methods. The first is the positioning of the patient, and that is prone, supine, or lateral. You can change the scan plane that way. The second one is positioning the gantry. You can angle the gantry caudal or cephalic. Number three, you can do both of those. And then the fourth way is by reformatting the image data that we get from our axial slices, which we'll discuss in more detail in the physics class. But you reformat those axial images into these coronal and axial images like you see on the screen on the slide here. In the past, it was better to actually scan the patient in the desired plane rather than reformat the actual scan, because the reconstruction methods were not as reliable or detailed as they are today. But with advances in CT technology and the software, that's no longer the case. So we save radiation dose by not scanning the patient in two different planes. Changing the image plane from axial to coronal is indicated for two distinct reasons. The primary reason is when the anatomy of interest lies vertically rather than horizontally. In our example on the slide, you can see in the images there, the coronal images and the axial images, you can see that the ethmoid turbinates lie predominantly in the vertical plane or in the coronal plane. And images taken in an axial plane show only sections of the anatomy with no view of the entire ethmoid complex. So images taken in the coronal plane are more suitable for displaying the ethmoid sinus structures and more readily shows any kind of obstruction. And you can see here that there's some pretty inflamed turbinates in there in the sinuses, so you don't see that here on this image. So the decision of whether to scan an axial or coronal plane is based upon the difficulty of positioning the anatomy of interest. And this is the main reason that protocols exist and are fairly uniform throughout the field. The second indication for scanning in a different plane is to reduce artifacts created by surrounding structures. For this reason, coronal plane is preferred for scanning the pituitary gland. The axial plane produces a number of streak artifacts, and partial volume effects are greater than in the coronal plane. And that's because of the petrous ridges bones that you're scanning through. So if you scan in coronal, then you're going to get nicer images to see the pituitary gland. But most scans are performed in the axial plane, but there are many head protocols that require coronal scans. All right, this slide represents an axial slice through just above the base of the skull and the brain. The arrows to the right of the image indicate anterior and posterior. So if you look, the globes of the eyes are anterior along with the nasal bone between them. And then the occipital bone is posterior in the bottom of the image. When you're viewing axial slices, it's helpful to envision the patient lying supine as you look up at them from the position of their feet, so that their left is on your right and vice versa. This slide represents a coronal view. It's similar to an AP view of a radiograph, and it helps to imagine that you're looking towards it, face to face, so that the patient's left is on your right and vice versa. This slide represents a sagittal view, similar to a lateral view of a radiograph. This is if you're looking at the patient from the side. Sagittal views are not as common or popular as coronal or axial views at most facilities, but they do have their usefulness. All right, the following information may be a review for some of you, but it'll help as we work through the sectional anatomy that we're going to cover. It'll help you understand it a little better and how fluid lies in the body and things like that. Those are important things that CT technologists need to know. It's found in a different text that you're not required to purchase, so just copy this information down because it'll probably be on the test. We're going to talk about body cavities first. There are two large enclosed spaces within the axial portion of the body that contain internal organs called closed body cavities. There are several smaller open body cavities such as the oral, nasal, and orbital cavities. The dorsal cavity is smaller and it's divided into the cranial cavity containing the brain and the spinal cavity containing the spinal cord. The larger cavity is the ventral body cavity. It contains the group of organs called the viscera or visceral organs. It's subdivided by the diaphragm into the smaller thoracic cavity and abdominal pelvic cavity. The thoracic cavity is divided into right and left pleural cavities and the mediastinum. The pleural cavities contain the lungs, and the mediastinum contains the pericardial cavity, which encloses the heart, and it also contains the esophagus, trachea, and the great vessels. The abdominal pelvic cavity is often divided into the abdominal cavity and the pelvic cavity. The abdominal cavity contains the stomach, the liver, the spleen, the gallbladder, the intestines, and the kidneys. The pelvic cavity contains urinary bladder, the rectum, and the reproductive organs. Membranes of the body cavities, these are thin sheets of tissue that line the cavities and cover the organs in the cavities and line the cavities of hollow organs. There are two types. First type is connective tissue membranes. These are membranes of the dorsal cavity and the joints. They cover the brain and the spinal cord and are called meninges. Then there's connective tissue membranes in the joint cavities, which are called synovial membranes. The second type is epithelial membranes. So epithelial membranes consist of epithelial tissue attached to connective tissue. Epithelial membranes that line open cavities such as the nasal cavity and the entire digestive tract are called mucous membranes or mucosa because they lubricate. Epithelial membranes that line the ventral cavity and cover organs that cover the organs are very thin, double-layered serous membranes or serosa. Serous membranes that line the ventral cavity wall are parietal serosa, which folds over on itself to form a visceral serosa, which covers the organ. Serous membranes secrete serous fluid for lubrication of the organs. Serous membranes are named according to their location. Parietal pleura lines the walls of the thoracic cavity. Visceral pleura covers the lungs. Parietal pericardium lines the pericardial cavity. Visceral pericardium covers the heart. In the abdominal pelvic cavity, the serous membranes are called the peritoneum. The parietal peritoneum lines the wall of the cavity, and then the visceral peritoneum covers the organs. It kind of folds up on itself and creates a couple of different places in the abdomen that we need to know about, peritoneal and retroperitoneal, which we'll talk about later. This slide demonstrates the parietal lining of the wall of the thorax and the visceral pleura covering the lungs, and the pleural cavity, which is the potential space between the two, providing a friction-free space for the lungs to move in. So looking at this, you have your potential space here between the visceral and the parietal pleura. This is the pleural cavity where a lot of the fluid builds up and can cause pressure on the lungs, and the patients can't breathe, and A lot of times we'll do a thoracentesis to drain that fluid out. But you see, here's your lung tissue. It's covered by the visceral pleura. There's the potential space, and then the parietal pleura is lining the cavity out here. So a visceral pleura is going to cover an organ. Parietal pleura is going to line a cavity. All right. This is going to conclude our the introductory portion of Lesson 1. And as I said, the introduction of this course, as we go through the different body parts and protocols, the lectures probably aren't going to be as long as they are in other courses, but they're going to require you to study anatomy that's going to be presented. So I'll just encourage you to utilize that extra time as you go through these short lectures to review the cross-sectional anatomy over and over, and all the protocols that we study, so that you can have those in your mind when you go to clinic, and you'll look like you know what you're doing. And by the end of this, you will. So we'll see you next time. Thanks.